Hi, so I'm Elizabeth Varga. I'm a genetic counselor here at Nationwide Children's Hospital. I've been in the field for about 14 years, and the last 5 I've worked specifically in pediatrics. So I see primarily pediatric patients who've been diagnosed with cancer, and at that time provide genetic counseling. Also, I'm a member of the National Society of Genetic Counselors and serve on the Pediatric Cancer Special Interest Group. I encourage any of you who haven't already seen the booth outside. There is a NSGC, our genetics organization, has a booth out there for any questions. So today I'm going to be talking about navigating the process of genetic testing and screening. And I know there's many families in the audience who really you could probably give this talk because you've lived it. But I'll just be providing a little bit more about some of the logistics of it, genetic testing questions, and then also just some of overlap. Actually, I realized Dr. Patino and I actually have some overlapping slides, which I can skip through, that cover some of the same psychologic aspects, because in genetic counseling, that is a large part of our role, is exploring all the family dynamics and things that are impacted when people undergo genetic testing. So the overview is that I will describe the process of genetic counseling and testing for Li-Fraumeni syndrome and examine some of the factors related to the family testing decisions, particularly when it comes to testing of minors, some of the ethical and psychosocial considerations, and discussing testing among family members. So as many people have talked about, the way that people with Li-Fraumeni are coming to attention has evolved significantly in recent years. So we had these classic criteria, which is demonstrated on this slide, where it's very obvious, where there's 3 generations affected. It's clearly autosomal dominant inheritance. So as people talked about yesterday, you need 1 genetic mutation in the TP53 gene to cause Li-Fraumeni, and then with each generation it would be a 50-50 chance to pass that on, and those who do not inherit the mutation cannot pass it on to their children. So in this family pedigree, you can see that there's a sarcoma, which is one of the classic tumors with Li-Fraumeni, diagnosed at 38 in the grandfather, and then a young breast cancer, and then a child with a choroid plexus carcinoma. So all of those are standard, part of the criteria for Li-Fraumeni syndrome, with an early age of onset, 3 generations affected, so this would be a very obvious family tree. And then, as people have also discussed, there are defined clinical criteria for when we offer testing. So a little background just in terms of genetic testing is that resources are scarce. So historically, genetic counselors were trained to offer testing when the likelihood of finding a genetic mutation is about 10% or more. It was kind of an arbitrary bar, but people have looked very closely at criteria. So for many years, we offered risk assessment as part of our evaluations, and we still do that, to kind of discuss with families before testing the likelihood of finding a mutation. So you can see here some of the criteria that are well accepted. So there's the classic criteria for Li-Fraumeni, and then there's other versions such as the Champray criteria, Birch, and Eales, which have been discussed at this meeting. But as you go down the list, it's less stringent criteria with the thought of finding more people and missing fewer people. So that's why the criteria have evolved. And there are the National Comprehensive Cancer Center guidelines that come out every year, so we constantly reevaluate these criteria to decide who the best candidates are for testing. So in this slide you can see where it's a little bit of a weaker pedigree, but it is still pretty, there would be no question about testing this family because the child has adrenal cortical carcinoma, which has a high risk of Li-Fraumeni syndrome, and then a grandfather who's affected. And this is a good example of what I see in pediatric practice, where people are still fairly young in terms of the parental ages, and so a child might be the one presenting to attention, and then you kind of uncover that a parent is affected. So I've seen this actually fairly recently, and it was a little bit traumatic for the family because we tested the child who was positive, and the grandfather had had a sarcoma, but he was 68 years old at this point and doing well, and there was a lot of guilt that kind of came out after that testing experience because the grandfather was constantly at the hospital and felt a lot of guilt that his grandchild was experiencing this, and he felt that he was to blame in some part. Also, the mother, she was adjusting to her child having cancer, and now she finds out indirectly that she has Li-Fraumeni syndrome and is at risk for breast cancer and needs screening. So certainly it can really be psychologically impactful. And then newer, kind of what we're coming across, is these isolated, sporadic cases of breast cancer where some people are undergoing just hereditary cancer testing for breast cancer alone. They may not even have a family history and represent a sporadic case, and they might be found to have Li-Fraumeni syndrome. And so in those cases, it's also a big surprise, because usually getting breast cancer at that age is quite shocking, first of all, and then to have a syndrome diagnosed is kind of a double whammy there, especially in families, where they're of reproductive age and starting to make these decisions about having children. And so then, as part of the risk assessment that's done in genetic counseling, we usually review kind of what's the chance of finding a mutation. So again, this has been discussed by other people yesterday, but about 70% of the time, if you meet the classic criteria for Li-Fraumeni, you will have a mutation found. I find the hardest genetic counseling cases to be those in which the family meets these clear criteria, but you cannot identify a mutation. So it's very frustrating because they don't have that documentation in their medical record to say, I have Li-Fraumeni syndrome. They don't really know how to explain that to people. They can say, I have Li-Fraumeni, but if they don't have a mutation, that sometimes is difficult for medical professionals to accept or to get the screening they need and justify that through insurance, even though they meet the clinical definition. And then there's these other criteria, the Champrey, Birch, and Eales, where the chance of finding a mutation is lower, but given these significant implications of Li-Fraumeni, we often do offer testing in all these situations because there is that chance that you can make the diagnosis. And then an important point is that you don't have to have a family history with Li-Fraumeni, because about 7 to 20% of patients will have a new mutation. They're the first in the family, but then it is transmissible from that point on. So in terms of obtaining genetic testing, I found all of the talks yesterday very enlightening because I realized this is an international conference. So in terms of what the resources are, varies significantly depending on where you live. So this is kind of the United States model. But for genetic testing here, it's often ordered by a healthcare provider. That could be a physician or a genetic counselor. And then we have certain standards for our laboratories, CLIA certification, CAP certification, that ensures that you're receiving quality genetic testing. And a big kind of buzz that's happening in the United States right now is there is a push to increase access to genetic testing. So one problem that when I work with families, they've found me, but they might have a relative that's in a very rural part of the country. They don't have access to genetic counseling services there. It creates a conundrum of how do I get this testing? So recently, there have been some labs that have sprung up that offer more of a direct access model. So they actually do not require necessarily that you have the test ordered by a physician in a clinic or a counselor in a clinic. They will actually mail you a saliva kit to your house, and you can spit in a tube, and you can mail it back. And some of them assign you a physician if you don't have one to go through that can actually just sign off the order, and they have genetic counselors, some of them on staff, that can speak to you by phone. And some of these also are being seen as advantageous by patients because the costs are lower. So there are some labs that do offer it much cheaper than in a clinical setting. So I think it'll be interesting to see how this evolves. My concern is, as we've already discussed, with all of the psychologic impact of genetic testing, also kind of some of the things that we'll talk about just related to variant interpretation of genetic findings, it can be very complex. So to navigate that alone without the help of a medical professional creates a lot of concern and angst among those of us in the medical community. And then in terms of future models, I thought the Brazil talk yesterday was fascinating in terms of newborn screening. So could that be something that becomes more common? It may. Certainly in our field, there's a big push for doing more and more whole exome or whole genome sequencing. So that would be not just testing for a single gene, but really looking at all of your genetic code, or at least a large part of it, for the coding sequence of the code, to determine really at birth or a young age, what someone might be susceptible to. So things I think in the field are definitely going to evolve over time. But right now, again, as we've already talked about, the syndrome is diagnosed either by clinical criteria, or you could have a single gene test, which is done through Sanger sequencing, where essentially they're just reading every letter of the DNA code. They're looking for usually typos where one letter or multiple letters of the code would be changed. That changes the message. Or that you might have a large piece of the gene that is either extra or missing that causes an error in how the gene is makes the resulting protein. So we usually do at least 2 steps, the sequencing step and deletion and duplication testing. And then once we have identified the mutation in a family, it's a lot easier because they can just be tested for that mutation that is in their relative, and that is targeted or site-specific testing. As we've talked about with next generation sequencing, this is what is allowing the cost of genetic testing to come down a lot in recent years. So rather than just kind of looking at the one gene, the way this method works is that you take all of the DNA, you cut it in little bits, and then basically there are probes that are used that have kind of the quote-unquote normal DNA code, and parts of your DNA are put in solution and they bind to that probe. And then basically it goes through a sequencing process, but it's all these little bits, and then they use computers to line up your code against kind of what we call a reference code. And so this has really revolutionized the speed in which we can do testing and the availability of doing multiple genes at once, which before we could not do. This is also why people are looking at larger genomic approaches, like doing everyone's whole DNA code at one time. But one thing that's tricky is the joke is always there's the $1,000 genome, so it might be cheap to actually do the sequencing, but the $1 million interpretation. So that's the problem, is that when you have all of this data, how do you really interpret the findings? And again, when you talk about genetic counseling dilemmas or dilemmas experienced by patients, it can be difficult when you have what's called a variant of uncertain significance. I know one person mentioned yesterday that they were found initially to have what was thought to be a pathogenic or disease-causing mutation for Li-Fraumeni, and then it later got reclassified as what we call a variant of uncertain significance. Basically, as presented yesterday, there's different evidence that is used to classify the significance of a genetic change. So you look at multiple factors and try to weight the evidence, like has it been seen in other people with disease before? How conserved is it when you look at multiple different genes from different animals and species? Is it seen in a normal population? And then we also have some tools that are more like modeling tools that help us to interpret whether or not a mutation is disease-causing. So the confusion I see a lot in the medical community is that, you know, it used to be more like you're positive or negative. It was pretty black and white when it came to genetic findings. And now that we have more data and more classification schema, we're coming up with all these variants of uncertain significance because we've kind of raised the bar for the interpretation of it being disease-causing. And then there can be benign findings that are common in the population, and they might be on a report, they might not. So I know some patients, since they've been here, they've been asking, should I know my DNA mutation? And I think I would recommend knowing that, getting a copy of your test report, just kind of asking periodically your physician or genetic counselor, like, is there any new information about my particular genetic variant? How is it being classified? How many families do we know have this? What are we seeing about the penetrance and kind of risk of cancer in families with this particular mutation? I don't know that we're really to a point where clinically we change a lot of what we do necessarily for most mutations, but I think that could change, and our goal is really to offer as personalized genetic counseling and screening as possible. And so another issue that makes everyone want to groan in the room is how do you pay for the testing? And that has been a question, and I was actually, when I was invited to do this talk, asked to specifically talk about it, even though I hate this topic the most. But genetic testing can be expensive, and in the United States, we have a big kind of issue with insurance paying for genetic testing. You can get coverage more often when we know that the results are medically actionable. It's going to change your medical management. And with Li-Fraumeni, now that we do have data to show some benefit of diagnosing this early, and we know that screening is beneficial, it's much easier to justify that. But I will say that even with that, there are certain insurers that blanketly exclude genetic testing, no matter what. And that is just something that's difficult to navigate, but I am certainly glad that now there are more opportunities with different labs offering either reduced costs, so some of them will cap the cost of genetic testing in terms of what the patient will owe. Others are doing more of a direct access model, so certainly there are things that can be explored, and I think the costs over time will go down. But right now in the United States, at least, we do have a hard time sometimes with getting coverage. The other thing I always remind people, though, is once a first person in the family undergoes the genetic test and you find the mutation, it's obviously less costly for relatives because you're doing that targeted genetic test. And then some of this was already touched upon by Andrea, but before testing, kind of what are the things we always think about? I can't tell you how many times I get someone writing me like, should I order this test? You know, a physician might ask that. And to me, I can never answer that question because, like, does the family want to do the test? Because that's how I think. And that's just because I'm so used to exploring all these psychosocial aspects and why, like looking at the rationale for why you're doing a test. So certainly you want to think about the likelihood of a positive result to start, how the result will impact medical management directly for that person, and then how the results will impact the family. Every family dynamic is different, and there are some issues occasionally like non-paternity that could be revealed through genetic testing or just the psychologic aspects of that. And then certain logistics like the costs of testing and what testing methodology you might use, because it could vary whether or not it's a breast cancer patient or someone with adrenal cortical carcinoma. So the test selection is also important. And then in the United States, again, it's important to also kind of touch upon some of the protections that are in place in regards to genetic discrimination. So the Genetic Information Non-Discrimination Act, or GINA, was passed in 2008, and it does provide protections for people based on either their just family history of cancer. They cannot be discriminated against anymore for that in terms of employment or health insurance. But there are some caveats to that. So with employment, if your company has less than 50 people, there's a caveat, or if you work for the United States government, there could be some limits to that protection. Also, in terms of health insurance, they cannot raise your individual rates based on a result, either your test result or your family history, but they could decide that, you know, you're a member of a small group and they could raise the entire rate for the whole group. So there are certain things like that that are limits. And then another limit is that it doesn't apply to things like disability insurance, long-term care, or life insurance. So sometimes people are encouraged to actually get life insurance before undergoing testing if that's a concern for them. And you can find more about the law on that website. Then the psychosocial considerations, as we talked about before, just feeling empowered. Some people feel very empowered to know that information, but some other people may feel a loss of control, or that they're, you know, this is their genetic destiny. So we try to work through all of that. And then also, as Amanda touched so nicely on in her opening on Wednesday night, is that she originally didn't feel like she was in a good place to undergo testing it as an 18-year-old, because she was thinking about, you know, her life and what she wanted out of her life, and did she want to know that information at that time, and how would it impact her dating or reproductive plans. So all of that is important to think about, and then at a later time she did feel ready to know that information. And then again, how it might impact the whole family. One thing that's kind of evolved also is the attitude toward testing of minors. So the American Academy of Pediatrics and other genetics organizations have guidelines about genetic testing in minors, and they kind of differentiate between predictive genetic testing, so that would be testing someone who's healthy and does not have cancer, versus testing after they have the diagnosis of cancer. So for predictive genetic testing, the guidelines state that generally you should not test a minor unless the disease does have manifestations in childhood, which we now know for sure Li-Fraumeni does, and that there are safe and effective screening programs available in childhood that could reduce the chance of death or reduce the kind of morbidity, which is just the consequences of the diagnosis. So for Li-Fraumeni, luckily we did have the Toronto protocol study that showed that there was clear benefit to screening. But before that, we really had a hard time justifying, in all cases, testing of minors. And I will say that there are still some professionals, maybe that do adult cancer genetics or things that might not be aware of some of those benefits in childhood. Also, in terms of testing, as I mentioned, that after a cancer diagnosis, there's less scrutiny about that because it's like, well, they've already had cancer, they've already dealt with that, so it's not maybe the same stigma, it's more of an explanation at that point. I've already talked about kind of the clinical and scientific advances that have allowed us to demonstrate an improvement. And then because of these advances, families in general, studies are showing that they are having an increased uptake of genetic testing. And in our early genetics literature, people often didn't want to test if there wasn't something actionable, something they could do. But now, in one study of Li-Fraumeni syndrome, they found that 92% did pursue the genetic testing of minors, and 95% if it was diagnostic, the child already had cancer, and 79% for predictive. And then Andrea had touched upon this, but for some people, that decision is very automatic. So almost half can make that very clearly. They don't even think about it. You know, it's like, of course I would do the test. And then 49% of the families really did have a more deliberated pro-con discussion, but most of them did decide to pursue testing. And then 6% had very difficult, deliberated, drawn out discussions. And for those families, as outlined here, some of the disadvantages that they saw were the psychosocial. A lot of them did have privacy concerns, discrimination concerns, and insurance issues. So for the advantages, which I think a lot of people in this room can identify with, is that they would want to know to promote their child's health, make sure they get the right surveillance and management, satisfy that need to know. There's definitely, once the question has been raised, there's some people that certainly like, I need to know this now. And then understand why the cancer occurred as an explanation, understanding their family risk better, so if they're family planning and have siblings at risk, research opportunities that are clearly opened once you have the genetic diagnosis, and then a feeling of benefiting others just by knowing the diagnosis or allowing for the option of family testing. And then, again, Li-Fraumeni does encompass everything, and it's not just the physical, it is more the emotional, and it's a family condition. And they've actually found in some studies that anxiety can be higher in those who are mutation negative, which seems very counterintuitive, but there can be a lot of guilt that is associated with being the one who is spared when you're watching this happen in your family. And sometimes patients come to me saying, you know, that they've really endorsed testing among their family members and they're frustrated because their family will not undergo testing and they don't really understand, you know, they feel frustrated because they see the benefits of testing. But certainly, I thought the Malaysian talk yesterday was intriguing because there are different beliefs, you know, based on your social, ethnic background, different family dynamics in terms of your attitudes towards medical care or just in belief of causation of disease. And so definitely all that plays in, and people are very individualized and they may react totally different even though they're a relative of yours to wanting the testing. They also might see how it would affect them psychologically quite differently. And certainly spouses and partners and other people in their life might influence their decisions. Also, age is a big factor, so we're seeing younger generations much more open to kind of testing and knowledge maybe than historically would. Or there's the question of really an older person might not feel that it's the same benefit to them. They've kind of lived their life at this point. They may not have the same need to know. And then some people may feel a lack of social support. So one study of Li-Fraumeni discussed, you know, some families, a lot of people have passed away. And so they may not even feel that they can cope with something or feel isolated, and that can influence their decision. And then certainly baseline levels of distress and anxiety. When giving results, it is very important from our perspective usually to talk to the family about how they even receive that result, because it can be a big piece of information. So it's not like something I want to call you in the grocery store as you're getting your test result. So we usually plan that out in advance and make sure that the person has like appropriate supports available at the time they might get the information, and leave with tangible products like their results report or a family letter that explains things. Hopefully identifying resources for them, such as all the great organizations here, and providing ongoing support either through us or a psychologist or support group or that type of thing. And then also, it's important, some families do have a difficult time reaching out to their family members and they don't really know how to bring it up. So there are these different methods that could be done, either in person. Nowadays, I can't tell you how many people are texting their relatives or posting it on Facebook, and that's how people find out. So that's a new thing that I'm learning to help people navigate. And then also, of course, there's telephone and things like that. And so certainly, I hope that people who do have access to a genetics professional can use their genetic counselor to help them navigate that process of contacting the family, and then identifying good resources that might be helpful in that family discussion. So to conclude, genetic testing for Li-Fraumeni is increasingly available. There are varying attitudes towards testing, and it is expected that the issues are complex. But advances, I think, in the clinical care of people with Li-Fraumeni and the research will continue to allow people to have a better sense of control when they have this diagnosis. And certainly there's social, educational, and healthcare provider resources that are available to assist those with Li-Fraumeni syndrome when navigating these decisions. So thank you very much for your time. I'm happy to answer any questions.
I'm Sujata. I'm one of the neuro-oncology fellows at Cincinnati Children's. And you mentioned about physicians doing genetic counseling. Is there any, I'm not trained in genetics, but is there any available course or online things we can do?
Yeah, that's a great question. Certainly there are, the one that I see advertised the most is that there's through City of Hope, with Dr. Weisel is here. I don't know if he is involved in that course, but City of Hope has a cancer genetics training course. So you could do like a short course in cancer genetics. I believe you might even be able to do that online. And then like our National Society of Genetic Counselors, they're getting more into provider education. There might be webinars and things like that. So certainly if you can identify like a short course, I think it would be very advantageous. Or I try, if you do have a genetic counselor, which I know you do at Cincinnati, you have lots of them, they have their training program there, and there might be opportunities for people on site to provide that type of education for you.
And the part you were mentioning about the coverage issues, I know at least at Cincinnati Children's, for certain tumor-related genetic testing that we do,
yes,
if the insurance doesn't cover, the hospital doesn't bill the family.
Mm-hmm.
At least the foundation one testing that we do.
Okay.
But I guess it depends from resources at every place. So
exactly. So
that makes a big difference. But
it is very different, and pediatric and adult practices often have different policies. So like for us, we do institutional billing where like our hospital actually pays the cost and then they bill the family. So unfortunately, even though that offers a lot of advantages because we can test Medicaid patients or get testing wherever we want in the whole country because we're paying for it, the downside of that is that we can't take advantage of some of the external labs payment programs and financial assistance programs.
thank you.
Thank you.
Good morning. I'm Patricia Prola. I'm a medical geneticist in Brazil, and I think we have a special situation in Brazil where we don't yet have genetic counselors as a profession, unfortunately. Mm-hmm. So the professionals that do counseling are mostly clinical geneticists or physicians trained in genetic counseling. Mm-hmm. And I wanted to actually just make a comment regarding the issue of the genetic testing approach. So I just wanted to comment on a little bit of caution. And I've seen in Brazil and in other countries, and I'm not so familiar with the situation here in the US, that there's a big push for testing with large gene panels and even exome sequencing. And we really have to be very cautious about that because What we really know about acting upon mutations is related to TP53 testing. So I'm always concerned when a patient comes to me and tells me, well, I've been told that I should do a large screening or a genetic mapping of my genome, because we know that we don't really understand well these alterations, and the broader the test we do, the more variants of a non-significance we'll have. So I think it has to be very clear when you order testing for a family that has a phenotype of Li-Fraumeni or Li-Fraumeni-like syndrome, that whatever is outside TP53 at this point is more like a research approach than really clinical testing.
That is absolutely true. And it's definitely, I think, a global problem because there is a lot of excitement about the technology, but certainly there's that risk of incidental findings or just things that people aren't prepared for going into that testing. So I very much agree with kind of limiting as much as possible so that you really are testing what you're looking for. So thank you.